And welcome this afternoon's GastroEcho session. As of course, it is hosted by the Gastro Foundation in conjunction with Project Echo, New Mexico. And as always, we'd like to thank them for their support. These sessions are held weekly on a Wednesday, and this is our last session for 2024. So we're rounding it off with liver pathology, and Prof. Martin Hale is going to take us through the enigma of granulomatous hepatitis. Over to you, Prof. Thank you.
Thanks, Bilal. Thanks for the introduction, and thanks for asking me to present. So I thought that this particular meeting we would end up with something that we all have a problem with, both from a histopathological point of view and also from a clinical point of view. And that is the biopsy that shows the liver biopsy, and for that matter, any biopsy that shows granulomatous inflammation. And granulomatous hepatitis is a particularly problematic area because of the need to really try and identify the cause of that granulomatous inflammation. So I've got 4 cases which do have a little bit of a story, and some of them the etiology of the granulomatous inflammation is known, and in other instances it's not. And it also just really shows, I mean, one of the questions that I'm often asked is, you know, you've diagnosed granulomatous inflammation. How long does it last? Particularly patients, for example, with tuberculosis and so on. And the answer to that is, unfortunately, we don't know, because we don't really go in once a biopsy is, at least a diagnosis is made, and rebiopsy those particular patients. One would certainly not dream of doing a second liver biopsy unless it was clinically indicated. Right, so the first patient then is a patient of Dr. Babu's that I'm presenting. He is a man of 43, and he initially presented in August 2023, so just over a year ago. He's HIV positive and was on treatment. He had chronic renal failure and a diagnosis of infection by Mycobacterium avium intracellulare was made in May 2023. He was treated for both tuberculosis and MAI, and he then subsequently developed deranged liver function. And of course, when patients are on anti-TB therapy, is it because of the INH? Is it drug-induced liver injury, or is it continuation of his current infection? So his liver enzymes showed total bilirubin of 16. The direct component was 7. He had an ALP of 504, a gamma of 866, an ALT of 45, AST of 41, and a total protein of 68 with an albumin fraction of 27. And this is something that we discuss frequently. Perhaps we could have some discussion in this maybe when we finish off the case. He had an elevated IgG of 29, so considerably elevated. And he also had a positive ANA with a titer of 1 in 160. So liver biopsy was done, and this is what was found. Right, so everybody hopefully should see that liver biopsy. And what we've got is a core of liver tissue. It's well represented. We've got at this magnification, you can see that there is expansion of the portal tract. You can also see that there is some fatty change in this biopsy. Good quality biopsy. We'll look at it in more detail just now. And then if we look at the reticulin stain, we can see that there is expansion of the portal tracts, as you see there. Greater expansion here and also here. And there's a suggestion, I'm sorry about the scratch on the plastic cover slip. There's a suggestion of a bit of architectural change, duplication and twinning of liver cell plates, and some disorganization to the trabecular framework in that region there. But it's not cirrhotic. And if we look at the serious red stain, the red is the collagen. So you can see the expansion of the portal tracts, broad expanses, that other area there where you've got this expansion of the fibrous tissue in the portal, excuse me, in the portal tract. But I don't think there's definitive architectural distortion. Certainly it's F2 fibrosis. And if we go to the back to the H&E, right, so if we start in this region here, this is the portal tract. And you can see that what we've got here is a portal vein. We've got, can't see the bile ducts 100%, with 100% certainty. I think there may be a bit of biliary epithelium I think this may be, some of this may be biliary, not 100% sure. But notwithstanding that, if we look under low power examination, we can see that this is a granuloma. And it's a non-caseating granuloma. And it's accompanied by a lymphocytic inflammatory infiltrate and also a couple of plasma cells. There's a plasma cell there. Maybe some of these are plasma cells as well. But there's no necrobiosis. And as we go elsewhere along the liver core, we can see similar changes. Here you can see a bile duct, for example, represented. You can see the portal vein, and I think that structure there is the hepatic arteriole. But there are two other things. This is a granuloma there, again, non-caseating granuloma, and then again another non-caseating granuloma. So here we've got a patient then who's got multiple non-caseating granulomata. We've got portal tract expansion by fibrosis, and we've also got culture positive history of atypical mycobacterial infection and also tuberculosis in an HIV positive patient. So I think it's fair to say that with this granulomatous inflammation is likely to be a cause, at least likely to be a manifestation of that mycobacterial infection, both MTB and also MAI. ZN at the time is negative, so was the pus stain, and that's not surprising. The patient has been on therapy, and the mycobacteria, in fact, die fairly quickly, and you don't see them. So I think that that would be a relatively open and shut case. I think that we can be fairly happy that the derangement of the liver function is unlikely to be as a result of the manifestations of drug-induced liver injury. And if one looks, for example, in the hepatic parenchyma, as you see there, you can see again that there's a small focus of granulomatous inflammation, this little cluster of epithelioid histiocytes, together with the odd neutrophil and also the odd plasma cell. So I think we would be happy with that. There's another granuloma in the parenchyma as well. Now, what I want to do, by way of just continuing the discussion, is go to the serous red and see if there are any other changes in the serous red. First of all, let's just pick up that granuloma. Okay, so what I'm going to do is I'm going to pick up the granuloma, which is situated in this region here. I'm going to pick that up on the serous red. Make sure that it's the right area. And there it is there. So there's a granuloma, same granuloma, and it's surrounded by a red staining of collagen. This is a serous red. And one of the features of sarcoidosis that separates it out from tuberculosis is perigranulomatous fibrosis. So I'm going to discuss it with another case that we're going to see later on. And this then is the Enigma, one of the Enigmas. So we've got a patient who we know has got mycobacterial infection and MAI. We also, both TB and MAI. We also know that the patient is HIV positive. So it would be a little bit inappropriate to suggest that this patient has sarcoidosis. We know also from the histology that these granulomas are non-caseating. So it can be very difficult to sort it out. So at that particular time, called granulomatous hepatitis and interpreted to be secondary to the patient's coexistent mycobacterial infection. However, the patient then presented back to Dinnan about a month or so ago. And in this particular instance, what we've got is another liver biopsy. He'd been on treatment for both TB and MAI, as I mentioned, and he'd had a relatively poor response to treatment. So he was biopsied again, and he also now has shortness of breath. The CT of the chest shows small nodules with cystic spaces, and he has cardiomegaly. He's also got a bit of central lymphadenopathy involved in both the chest and the abdomen, and he's got a hepatosplenomegaly. His workup for TB is negative. His weight's improved, and his B symptoms have settled. CD4 count is 358, and he's well controlled on antiretroviral therapy. So his liver enzymes show a total bilirubin of 9 with a direct of 4, ALP of 290, a gamma GT of 367, ALT of 29, and AST of 38. Interestingly, he has an elevated IgA of 20, an elevated IgG of 32, and an IgM of 0.6. So he got considerable elevation then of his IgA and IgG. But now his serology, and this is once again this enigma, positive anti-nuclear antibody with a titer of 1 in 80. He's got a mid-positive AMA M2, equivocal GP210, an equivocal SLLP. And this is what his liver biopsy looks at now, as of November this year. And I'm sorry about the poor cover slipping. It's separating a bit, which is why it's showing this artifactual change. You'll have to ignore this and see through this. But what you've got here is you've got a liver biopsy now. And if you think about the previous liver biopsy, I'll just put that on again to show you. I'd like you just to have a look and sort of in your mind, just make a mental check of the extent of the blueness, because the blueness represents the inflammatory infiltration. In the current biopsy, you can see that it's considerably worse. You can see it's much more extensive. Look at this, quite florid, in fact. And then when we look down more closely, we can see that we've got this intense lymphocytic and plasma cell infiltrate. You look here, for example, this clustering of plasma cells. If I can just pick that up on the screen, we've got clustering of plasma cells. And when we see that, now we look at the serology and we see that the serology is highly suggestive of an autoimmune component. I mean, just have to look at the edge of this biopsy here, and there's a little sheet here. There's a cluster here. These are all plasma cells. So autoimmune hepatitis does have to come into the equation. You've also got interface inflammatory activity as well, as you see there. And I think in some areas, there's also participating plasma cells in this interface inflammatory activity. So we've got this profound portal-based inflammatory infiltrate. And then when you look here, you can see now that you've got persistence of this granulomatous inflammation. We've got multinucleate giant cells. We've got another granuloma there. Got another multinucleate giant cell here. And we've got quite extensive spotty inflammation in the lobular, at least in the lobular parenchyma as well. Just seeing if I could find some plasma cells to show you. So here you are. So look at this. This is the edge of a nodule here, and these are half a dozen plasma cells that are participating in this interface inflammatory activity. And again, more plasma cells, for example, here, and again there. So now, what is happening? And therein lies the problem, because we know that he's had atypical mycobacterial infection. We know he's had TB. He's been treated for both. And yet, you don't really seem to have what we would regard as an acceptable response for therapy. And he's also got positive serology for the PBC markers. So when we concluded the report, we said it showed changes of cirrhosis. We thought that he was probably cirrhotic, because if you look at the reticulin and the Masson trichrome, that is starting to come through. For example, there, you can see that nodularity, much more fibrosis than in the previous biopsy. Look at that there. Quite striking. All the way through. And if he's not cirrhotic, he's certainly F3 and probably going on to cirrhosis. And we said that he's got this persistent granulomatous inflammation, which we think is unexplained, and or which is unexplained. We think that he's also got an autoimmune component to this as well. And he's also got possible overlap syndrome because we could only see native bile ducts in 21 of the 28 portal tracts. So a bit of an enigma. And when I spoke to Dr. Parbu earlier on, just before the meeting, he's unfortunately can't be present at a meeting. This is the CK7, and it just shows you the extent of the bile ductular proliferation that's present in this biopsy. And there are some portal tracts that are devoid, for example, this one here, of any native ducts. So it looks as though we've got a ductopenia, we've got granulomatous inflammation, we've got incipient cirrhosis, we've got serological features of autoimmune disease. And to be honest, we're not really sure what his actual diagnosis is. So I open it up for discussion, but I think it fits very well the enigma of granulomatous inflammation.
Thanks, Prof. Absolutely. There's just so much confounding this poor gentleman's diagnoses from the various drugs that he's on for his retroviral disease, the Mycobacterium avium, the positive autoimmune markers, elevated IgG. Elevated IgG, could it just be the HIV, or is there something truly autoimmune going on? I think from what I recall, his viral load had responded to therapy, and his CD4 was at least low but stable. So certainly a problem. Sandy Masenia has posted a question. I noticed that there are steatotic droplets around the granulomas. Are these typical to see in sarcoidosis, or the patient happens to also have some steatotic liver disease, whether it be metabolic, ALD, or a combination?
Yeah, so I think probably a combination. It could be metabolic. A patient with HIV can develop fatty liver disease. Could also be TB. You can sometimes get a bit of fat with TB. Yeah, we don't know. It could be.
Martin, just clarify the pericellular the perigranuloma fibrosis.
Yeah, so Chris, I've got a case just now, which I think is sarcoidosis, and that shows that fairly well. So one of the tricks we can use to separate out sarcoid from TB is pericellular, perigranulomatous fibrosis. If you've got perigranulomatous fibrosis, that tends to suggest that it's sarcoid rather than TB.
Okay, thanks.
Absolutely.
And then just straight with the HIV, I mean, I wouldn't have necessarily called him overweight by any means. He's actually probably underweight and relatively sarcopenic. So whether or not there's something more nutritional going on with those steatotic droplets, I don't recall getting a history of alcohol use. So I think this is one of those multifactorial aspects. And remembering that, your list of hepatic granulomas, I think there's over 50 different causes. If you have a look in any of the hepatology textbooks.
Yeah, absolutely.
Bilal, therapeutic options. I mean, this guy's progressing. Steroids.
I think that's what they actually settled down on, giving him a trial of low dose steroid and see what he does. I think they went for 20 milligrams for 3 to 4 weeks, cutting it down to 15, and then reviewing him at 6. That's what I recall. Martin, I'm not sure if you and Dylan had any further discussions.
Yeah, I think that was the idea, was to maybe give him a course of steroids, to see because there's not much else left. If you think about it, he's had his TB therapy, he's had his MAI, he's got no evidence of active infection from that point of view. I did suggest that maybe we do a bone marrow culture, because that's quite.
Well, it's done, and I think when I last checked, still pending. Because
Yeah.
that's going to take a few weeks.
Yeah. Also, just to mention that the fat disappeared between the first biopsy and the second biopsy.
Yeah. Yeah, I think
Okay.
I think that was more just his illness, wasting, in terms of metabolic fat deposition.
Okay, right. So let's move on if there are no more questions about him. So the next patient. Yeah, thanks, Bill. Our next patient then is a 54-year-old man. He was found to have abnormal liver enzymes, and I don't
excuse me.
think it's for you, bless you. Had abnormal liver enzymes, he had elevated alk phos and a gamma, and an etiology for that had not been found, and serology for autoimmune disease and viral hepatitis was negative. So liver biopsy was done, and this is the biopsy. And this also is an interesting story. And I don't know about the BMI at that particular stage either. So what we've got is a biopsy. Let's just put on the retic and the serious red, just to give you an idea of the architecture. And I think probably one of the things that you have probably noticed is that when certainly I look at these liver biopsies, I go backwards and forwards from one stain to another. And I tend, from a point of view of a habit, I've got a particular sequence in which I look at the biopsies. And sometimes I'll skip out things. So, for example, if it looks like the bile ducts are disappearing, I'll go straight to the Orsine stain and have a look. But one of the things that I do certainly is jump around. So I'm sorry about that. If I'm, if I may be causing a bit of confusion. And the reason for that is because as things come to mind, so we go to other areas of other particular stains. So this then is the biopsy. This is the reticulin. And you can see that there is expansion of some of the portal tracts, another portal tract there. And I think if you go down and have a look here, you can see that it looks as though something may be happening in that region there. We seem to have some entrapment of hepatocytes, maybe one or two other cells as well. There's a little bit of fat. And also just to point out, as I mentioned in our earlier working meeting, that often if you get a bit of steatosis, that tends to cause fragmentation of the reticulin. So you lose the reticulin framework. So for example, that there is preservation of the framework, but the fat for some reason seems to destroy the reticulin framework. I guess it's because of the distension of the liver cells by the lipid droplets. And there's another focus there that looks as though there's something that may be going on. When we go to the serious red, you can see that picture is repeated. You've got collagen deposition, for example, in some areas there. We'll come to that there, and we'll come to these areas here. So let's go back to the retic, and it's to the H&E. And I'm sorry about the folds, the temperature of the water bath, I don't think was properly kept when the sections were floated out. So what we've got is we've got portal tract expansion by fibrosis. And then, for example, here, just next to the portal tract, we've got this focus of granulomatous inflammation. Now, when we see this is, and you've seen probably in our reports, we talk about relatively clean granulomata. Now, what do we mean by that? What we mean is that there is not much associated inflammatory infiltration. When, for example, you get granulomata secondary to fungal infections, or to tuberculosis, there's often a significant accompanying cellular infiltrate in the form of plasma cells, lymphocytes, or in the case of fungal infections, neutrophils. And in atypical mycobacterial infection, you also get a neutrophil inflammatory infiltrate as well. But here you can see that you've got these epithelioid histiocytes. Why do we call them epithelioid? In this particular instance, because they look like epithelial cells. Okay, those are not hepatocytes. These are histiocytes that resemble epithelial cells. And if you look at the periphery, they're pretty clean. There's not much in the way of an inflammatory infiltrate. There are a few plasma cells here, and there's one plasma cell there, a couple of lymphocytes as well, but nothing really major. Typically, the inflammatory infiltrate is at the periphery of the granuloma, as you see, for example, there. And if it's necrobiotic, sometimes you'll see caseous necrosis at the center. Turning to the portal tracts, there's a bit of a lymphocytic inflammatory infiltrate. And when we go through that, you can see the fat, and then there's another granuloma as well, once again, portal-based, multinucleate giant cell. There's the bile duct, clean-looking granuloma, another one there again. And let's just see that I'm looking for. Yeah, here we are. Right, so another trick as well. Histopathologists always got tricks up their sleeves. Sometimes they work, sometimes they don't. But in this particular instance, you can see that we've got a giant cell here. And if I turn the condenser out, you can see that that is refractile. And then I'm just going to put on the polarizers to see if it is doubly refractile. Because if it's doubly refractile, that would suggest that it is foreign material. So that's it there. And if we turn this, we can have a look, and it disappears. That's where it should be. Can't see it, so it's unlikely to be foreign material. And we wouldn't expect that. Now, I mean, you know, you must always expect the unexpected, as we say. In this particular instance, these are, and I've forgotten the name. I wonder if I've reported it. I'm not going to embarrass myself by trying to remember the name, but there are something that begins with an H, if I remember correctly. But anyway, there are specific bodies, inclusion bodies, that are seen in patients with sarcoidosis. And that's what this is. So this is a patient with sarcoid, and you get these little bits of inclusion material in the giant cells. Now, what I want to do is I want to go to and unfortunately, with the levels, so
Asteroid bodies.
yeah, asteroid bodies, but there's another one as well. Hamza something or other bodies.
Hamazaki-Weisenberg.
Thank you. Thank you, Washington. Well done. And
Sorry, just repeat that.
It's Hamazaki-Weisenberg. I'll write it in the chat.
Thank you.
so what I want to do is I'm trying to, because I've got another trick up my sleeve. And I want to go to this here. This is the Sirius red. Once again, jumping around. And there is a granuloma, which has come out on the Sirius red. And you can see that you've got this perigranulomatous fibrosis. And there's another one, the capsule. And that
beautiful, yeah. Mm.
very well demonstrates the perigranulomatous inflammation. Unfortunately, it doesn't really come up on the H&E other than let's focus here, because obviously you're cutting deeper into the biopsy. And it was underneath the capsule here. So it's not actually evident. I think this is the beginnings of it. So, yeah, so that is sarcoid. Now the plot thickens because the patient was treated and didn't get better. So he had another biopsy that was done earlier this year. And what I'd like you to do is just, sorry, jumping around again. What I'd like you to do is just take a photograph in your occipital cortex of these granulomata. Look at the size of them. Look at the cleanliness of them. And another one there. You know, that's the sort of thing that the village policeman can diagnose. You can see those. You don't need a histopathologist to diagnose those. But on the repeat biopsy, because he didn't get better, so the gastroenterologist decided to repeat the biopsy. And this is now 2 years later, because the first biopsy was done in 2022, in October 2022, and the repeat biopsy was done in July this year. And here is all that we have left. We've got this little, small, non-caseating microgranuloma. So he was treated with steroids, but didn't seem to be making a clinical improvement. And therein lies the enigma again. So we said that the first one was granulomatous hepatitis. And in fact, I took pictures of before and after treatment and included those in the report, because it's quite difficult really to be certain as to why he continues to be relatively ill. And he has intra-abdominal lymph nodes. Those were not really biopsied at the time. Showed a little bit, well, in fact, it showed a bit of lipid granulomatosis unrelated to this. But his sarcoid in the liver seems to have disappeared, and all we're left with now is this here. So another enigma. So I don't know if we want to discuss that, if anyone's got any discussions about him. Okay, let's move on. Bilal, your patient.
Yeah, so this is Mr. JS, is that correct?
That's right.
So Mr. JS, unfortunately, was seen probably about 2012, 2013, when they'd already noted features of metabolic associated liver disease, NASH at the time. And he was given some advice and sent along his way. Unfortunately for him, part of his weight problems stemmed from the fact that he was on a number of psychiatric medication for his bipolar mood disorder. And those chopped and changed. And with that, it increased his appetite and led to steady weight gain. He was then referred to me for another opinion, it now being, just over 10 years down the line. And I was concerned that with his platelets already dropping and a bit of a bulky spleen, that he had now progressed to cirrhosis. A biopsy was performed for that purpose, as well as to exclude any concomitant pathology.
Right, so thanks, Bilal. Right, so we continue with the enigma of granulomatous inflammation. So now we look at this biopsy, and as Bilal has mentioned, put on a bit of weight, and what do we see? But we see fatty liver disease. Lots of fat, mixed small and large droplet steatosis. There is evidence of ballooning, as you see here, extensive ballooning. The large droplet component, just sort of eyeballing it, looks as though it's at least 50 to 60%. I don't know what I put in the report at that particular time, but certainly well over half of this is liver. In fact, in some areas, it looks as though it's getting to 70 to 80%. So he's got significant fatty liver disease. There are foci of steatohepatitis. Not many of them. And you jump to the serious red. And lo and behold, there's not much fibrosis. So there's a portal tract there. And there is a little bit of perivenular fibrosis, a little bit of sinusoidal fibrosis here. So this would be a brunt stage 1. The grading, I think, would probably be forced to call it at least a 2 and maybe a 3. I don't know because of the extent of the steatosis. Yeah, in fact, I called it a grade 3. And in fact, I also called it a stage 2. But I think the reason, Bilal, if I remember correctly, was because of a little bit of septum formation. And you can see here that there's a bit more sinusoidal fibrosis as well in zone 3. And I think really it was also to make sure that we try to induce or enforce a lifestyle change in him. So you call it stage 2 grade, grade, what else call it? Grade 3, stage 2. So he's got significant fatty liver. But the story doesn't end there. Because you go down the liver, and in that portal tract, there is a granuloma. Once again, relatively clean, got a multinucleate giant cell, got a couple of plasma cells in this region here. And then when we go to the second biopsy, we see there's a little microgranuloma here. That sort of thing there. And another microgranuloma there. once again, portal-based, and in this particular instance, also accompanied by a couple of neutrophils there. But it's non-caseating. And when we go back to the previous one, did I show you all three? I can't remember. So there's one there, yeah. Another one there. Yes. It's the other one. The other one's disappeared. Wrong level. Yeah, and there's a little granuloma there. And the interesting thing about this little granuloma is that it does seem to be associated with some fat. So with steatosis, you can get microgranulomata as part of the steatotic process. So it could be that the granuloma here are associated with the fatty liver. However, what is unusual is this. In fatty liver, you wouldn't expect to see a granuloma sitting in a portal tract. And therein lies the enigma. Why is that there? So, Bilal, over to you. I'm sure you investigated him for sarcoid.
Yeah, still waiting on him to actually do the bloods that we'd requested. But additionally, the feeling was he is also on so many
Drugs.
medications and drugs that this could very well also be drug related. But yeah, I am waiting on him to do
Okay.
it.
Yeah.
So how do you explain the thrombocytopenia and splenomegaly?
It was relatively
sarcoid?
mild. Yeah, it was relatively mild. So I think if it's sarcoid, there might be some portal-based inflammation with the sarcoid, kind of pushing up those portal pressures a little more than what we were anticipating. Yeah, that might be it, but he's certainly still a project in progress.
Yeah, thanks, Bilal. So the last patient in the last few minutes is a current patient that I'm working on, but I thought it would fit very nicely while I scratch around in my paper. So this patient then is a woman of 69. And she has some mental health disorder. I have been given the drug history, which I've still got to look at. She has been investigated she was found, I think, if my memory serves me correctly, basically to have a markedly elevated calcium level. I think there's also an element of confusion because of the mental health disorder. But she's got a markedly elevated calcium. She's got a decreased PTH, parathyroid hormone, and was interpreted to have secondary hypercalcemia. She has an amylase present with pancreatitis as well, and thought to have hypercalcemia-induced pancreatitis with an amylase of 3,200. The top and tail endoscopy was normal, and serum protein electrophoresis was also normal. CT chest showed mediastinal nodes, but those have not been biopsied. CT also showed an infiltrate in the liver and thought to be fat, but could it be something else? The enzymes, liver enzymes, which were done about a month ago, no, 2 weeks ago, showed a total bilirubin of just find that these Lancet labs are all over the place these days. Total bilirubin of 7 with a direct component of 3. The gamma was 105. The alk phos is 97. The ALT 39, AST 45. Total protein of 82 with an albumin fraction of 45. Serum calcium was 3.1. So the upper limit, as you know, is 2.5 for Lancet. And parathyroid hormone was 7. So a liver biopsy was done. And when we discussed the liver biopsy, so I'm just looking around here, I was told that the ACE was normal. So this is the liver biopsy. And this is, I mean, this is the amount of fat in this biopsy is enormous. This is the retic, and you can see that there is certainly some disorder to the reticulin stain. There does seem to be expansion of the portal tracts, and I think there may be a bit of linking. I said this is still work in progress. See a bit of linking here. When I discussed the patient yesterday with the physician concerned, says she's got granulomatous hepatitis. And if you look, you've got multiple, I think this is the beginnings of a granuloma there. Not going to bore you with that detail. But here, for example, there is a classic sarcoidal type granuloma there. Notice the peripheral rim of lymphocytes. It's also a portal-based granuloma as well. And then we've also got foci, I think, of steatohepatitis, little granuloma here. And this is the problem, because now this granuloma here is non-caseating. It's associated with the fat. It could certainly be part of the spectrum of steatohepatitis. And then if we go to the Sirius red, there's that granuloma, and it's surrounded by that puff of collagen.
Nice.
So this looks as though it's a sarcoid type granuloma, and her serum ACE is 91, elevated. So the question then is, I mean, that with that hypercalcemia, be interested in your thoughts, because the discussion was that didn't think that the serum calcium would go up that high with sarcoid, but I think it's probably a sarcoid. And then we've got these little granulomata as well, these microgranulomata in the liver. Is that part of sarcoid, or is it part of steatohepatitis? And I'm not sure that we'll ever really sort that out. But I think that she's actually got sarcoidosis as a prime disease. So I'd be interested in your thoughts. As I said, work in progress. So I'm looking for advice. And that basically concludes the presentations that I've got.
Yeah. So I think that, you know, what's going to be important, I think, moving forward with interpreting a lot of these is that steatotic liver disease and hepatic steatosis are just going to be that much more common. And in patients with autoimmune liver disease, whether it be sarcoid, autoimmune hepatitis, you're going to still see some fat with where you're not necessarily expecting it, and the potential for dual pathology exists. If you look at the last AASLD guideline looking at autoimmune hepatitis overlapped with MASLD, they make this point, and they also point out that, you know, it complicates your management, because on one end you're trying to get them to lose weight, and then the other side it's giving them steroids or glucocorticoids, which will worsen their insulin resistance. So yeah, it certainly is going to be interesting, and it'll be interesting. You know, I'm curious to see what path the clinician took in managing this, because that certainly is an enormous amount of steatosis that she has. I mean, it's almost a white screen.
Yeah. And if you look at this, I mean, these are 2 microgranulomata, one there
Yeah.
and another one there.
That's
And
the parenchyma, really.
yeah. And the problem here is that sarcoid, or is it granulomatous steatohepatitis? And the parenchyma is full of these microgranulomata.
Yeah.
And the ACE level, 90, would you accept that? 91?
Sure.
It's a bit
Yeah.
up. You know, she's also hypercalcemic.
Yeah.
And I mean, look, you know, any granulomatous disease is a cause of hypercalcemia. You know, there are other things to look at. CD4 to CD8 ratios would be one. Looking at X-rays for any other extrahepatic features of sarcoidosis would be another. So there's still a little bit more clinical legwork to go here.
Yeah. We just look at this here. Look at this granuloma.
Yeah.
Morton-based granuloma. I just put on a dot on it. Ah, where's it gone? Look at that. A more typical sarcoidal granuloma you couldn't get. That's a textbook picture.
Yeah.
So yeah, that's the enigma of granulomatous hepatitis.
Absolutely.
Great, thanks. Thank you, Martin.
Anyone else with any further points or questions? Sandy, are you still on the meeting? There we are.
Yeah, I'm here, Bilal. I don't have any questions. Thanks, Prof, for the
Yeah, any
teaching.
comment?
That's a pleasure.
Yeah. No, great. So everyone, it's just after 5:30 then. I'd like to thank everybody for joining our last meeting of the year. Prof. Hale, thank you for being such a stalwart in this regard. And you know, obviously to the University of New Mexico ECHO team, ECHO India, and the Gastro Foundation. I'd like to hand over to Chris just to complete the closure of the meeting and see everybody next year.
Thanks, Bilal. Martin, thanks so much. Yes, it's our final year, so some thanks from me. A final session for the year. So thanks, you know, from me to ECHO India and to the team in Cape Town and to all our sponsors, and of course to all of our colleagues and friends who sign up every week for our sessions. It's really gratifying to see how these sessions are growing and the interest is increasing. And of course, to the foundation that facilitates these sessions. So we'll start next year on the 22nd of January with an upper endoscopy session. We're also we're adding an extra gecko session on pancreatology to the existing sessions that we already hold. So I hope that will draw some interest and increase the repertoire. So from me, on this glorious sunny day in Johannesburg, I hope you all have a nice break. Happy holidays for those that are traveling, safe travels, and we look forward to seeing you back here on the 22nd next year. So from all of us, thank you very much and goodbye. Thanks, Martin. Thanks, Bilal.
Pleasure. Chris, there was a question about CPD.
Yes, we must look at that, and also ethics for next year. Yes, we must. We've been speaking about it, and we certainly will look at that. Thank you. And of course, I'd like to, personally thank Cheryl for all her hard work and consistency and her level-headedness at times of crises. Thanks, Cheryl.
Thanks, Chris.
Okay, bye everyone.
Cheers, mate.
Everyone, bye-bye.
Bye.